Welcome everyone to tonight's 8th installment of the AAFP COVID-19 webinars. My name is Dr. Chris Scuderi, and I've had the pleasure of chairing the AAFP's COVID-19 Task Force, which has been leading the AAFP's efforts to assist Florida's family physicians and their staff in dealing with the COVID-19 crisis. Tonight's topic, Return to Clinic, a pragmatic approach to resuming face-to-face visits, will address several critical issues, including reviewing relevant guidance from the CDC, AMA, and AAFP for safe return to seeing in-person visits, discussing medical liability and malpractice concerns, and address lessons learned from a DPC as well as a large employed group viewpoint. Our presenters tonight are both AAFP board members, Dr. Craig Levoy, who serves as Medical Director of the Bayfront Health Medical Group in St. Petersburg, and Dr. Matt Rensberry, a direct primary care physician practicing in Orlando, who was previously on faculty at Advent Health Family Medicine Residency and trained and served in the United States Army. Before we begin, just a reminder that similar to all AAFP webinars, participants will be in listen-only mode, but can type questions in the chat box that you presenters and I can see, and we'll attempt to answer either during or at the end of the presentation. Also, stay tuned as the AAFP will be planning a town hall webinar in the coming weeks to discuss the aftermath of several issues, including the 2020 legislative sessions and the COVID-19 and more. Now let's get started by turning the presentation over to Dr. Levoy, who will be managing the slides and the discussion between himself and Dr. Rensberry. Craig, take it away.
Thank you, Dr. Scuderi. Hello, everyone. Good evening. Thank you for joining us tonight. My name is Dr. Craig Levoy, and as Dr. Scuderi mentioned, I'm joined tonight by Dr. Matthew Rensberry.
Yes, good evening. I'm Dr. Matthew Rensberry. I run just a small practice here in Orlando.
Tonight we have no disclosures for either myself or Dr. Rensberry. As Dr. Scuderi mentioned, tonight we will be reviewing when to resume face-to-face visits. We'll also discuss how to resume face-to-face visits. We'll review national guidelines from CDC, CMS, AAFP, and the AMA. And we'll also discuss lessons learned. We will have time at the end for questions and answers. So we'll start by saying when to resume face-to-face visits, and we'll preface it with saying that for some of you, you never closed. You never stopped seeing patients face-to-face, and we recognize that. And so we hope that for those of you who have continued seeing patients face-to-face throughout the COVID-19 pandemic, that this webinar will help to instill some pragmatic lessons that have been learned in terms of safety for our staff, safety for our patients. And for those of you who may have closed either partially or completely face-to-face visits, we hope that this webinar is useful in a tool for how to resume those visits. With that, I'll turn it to Dr. Rensberry.
Hi, so regardless of how each of our practices have responded during this pandemic, all of our practices and our internal procedures have been affected in some way. Let's look at what we have to help guide our decision on when to resume our face-to-face visits. These here are three variables that we can use to make that decision, and starting with the local prevalence of COVID-19. Next slide. There's official guidance from the White House, guidelines for opening up America again. These provide gating criteria for state reopening. This is a three-phase approach based on advice of public health experts with steps to help state and local officials to reopen their economies. Before reopening, these gating criteria are essentially to be satisfied: a downward trajectory of influenza-like illness and COVID-like syndromic cases for a 14-day period. Also, a downward trajectory of documented cases in a 14-day period, or downward trajectory of positive results as a % of total tests in 14 days. Next slide. So how do we estimate our local prevalence? Florida Department of Health has done a great job throughout this time frame with data communication. This website provides daily updates, and I'm sure most of us are very familiar with the dashboard by now. Next. Next slide. On this dashboard slide, if you go to the health metrics tab, which you can see down at the bottom, it shows the emergency department visits by influenza-like illness, the emergency department visits with COVID-like illness, documented new cases, and percent positive for laboratory testing over time. Those are all the gated criteria. I would like to also bring your attention to the drop-down menu at the top right side, where you can choose the county where your clinic location is and the counties where your patients reside in.
Next, we'll move on to availability of PPE. So again, when we're discussing when to resume face-to-face visits, it's really important for us to have an understanding of our in-stock of PPE for ourselves as providers, as well as for our staff. Without adequate PPE, it would not be possible to see patients in a safe manner during the COVID-19 pandemic. If you're like me, you may feel that, at least at the onset of the COVID-19 pandemic, that what we needed was on the left-hand side of your screen, and this is what we got with the gentleman coming down the stairs on the right-hand side. Of course, over time, we've had some improvement in our PPE availability. It's important that whether you're part of a large employed practice, whether you're part of an independent practice, that we have access to PPE. Obviously, based on your historical vendor relationships, that may become more or less difficult. And so we are recommending as tips that you discuss with your local hospital systems, as well as other groups in the area, to perhaps cohort, and if you're having difficulty obtaining appropriate PPE, to reach out to your local resources. Part of those local resources might in fact be the FAFP. I'm going to take this opportunity to do a little bit of a shout out for the FAFP. As most of you are aware, early on, the FAFP Board of Directors was able to obtain a number of KN95 masks that were distributed at no cost to a number of FAFP members who are on the front line. And so organizations like the FAFP have your back. They understand the importance of PPE. And if, as you are going through the gating criteria determining when to resume face-to-face visits, you're having difficulty obtaining PPE, I want you to know that the FAFP is here as a resource for you. That said, the best tools are going to be to utilize the vendors that you already have relationships with. Appropriate PPE is going to be determined by the local prevalence of COVID-19, as well as what type of patients you are seeing in your practice. We'll get to that in a little bit later in the presentation, but for the most part, it means that at a minimum, a face surgical for all patient interactions, plus or minus face shields and goggles. So it's appropriate and important to take stock of your PPE. The next gating criteria would be COVID-19 testing supply. So your local ability to obtain COVID-19 testing. And in this case, we are talking more about PCR testing as opposed to antibody testing. This is a snapshot from the CDC in terms of the number of specimens that have been submitted to public health laboratories since the onset of the COVID-19 pandemic. You'll see that the CDC labs represents a significant minority of the number of cases that have been tested. The vast majority have been through public health labs, including public-private partnerships. Some practical tips in terms of determining if your local area has enough testing supply. First resource would be to contact your local Department of Health to determine where your available testing sites might be. We do recommend that you identify several testing sites in your catchment area. So if there are any supply issues, you may have an alternative to send your patients to for testing, as well as to determine if we are having turnaround time issues. It's really important to understand the turnaround times so that way you can appropriately counsel your patients on expectations. We have seen, obviously, at the beginning of the COVID-19 pandemic, turnaround times of over 2 weeks. And most of us are seeing anywhere from hours to 48 hours of turnaround times of tests at this point. So we'll move on to how to resume face-to-face visits. So assuming that you have adequate local understanding of your local prevalence, you have availability of PPE, and you feel that you have adequate access to COVID-19 testing for your patients, whether on-site at your own clinic or at area testing centers, you would then move on to resuming face-to-face visits. Most of your patients have been at home, and there might be a built-up desire to see their provider in person. There may be some boredom associated with being at home. Most of them have probably finished Netflix at this time. So for many of us, the surge that we're going to see was not necessarily during the COVID-19 onset of the pandemic, but in fact, it's going to be our return to patient face-to-face visits, especially patients that were either afraid or delayed high priority care, and now may have had comorbid conditions as a result of it develop or worsen over time. There are a lot of official guidance out there right now. What we've tried to do to distill this down was to highlight three main guidance that have come out from the CMS, which really comes mostly from CDC guidance, AAFP, and AMA. There's a lot of overlapping themes throughout these guidances, and so we've taken the highlights of all of those in hopes that this is a useful toolkit in determining how to resume face-to-face visits for your clinic setting. I would pause here and say that all of us practice in very different logistics and very different types of practices. And so none of this will be prescriptive. Instead, it will be recommendations. And most of us will need to take these recommendations and apply them in sometimes creative ways in order to fit our practice type and our patient panels, as well as a reality of our COVID-19 prevalence locally. And so these are truly recommendations and not really prescriptive. The overall highlights here, we're going to talk about these in turn: incremental opening, scheduling and triage, screening patients, patient communication, visitor policy. Again, we'll highlight PPE, talk about how to protect your staff. We'll also talk about facility considerations. Matt?
So as we start off this part of the discussion, we discussed the idea of opening incrementally. Resuming 100% face-to-face visits is probably not best to occur overnight. And so I think in this time, it's to think of this as a stepwise approach of phases, so as to protect yourself, your staff, and your patients. You might consider measures to protect staff, such as bringing back your employees in phases. You consider utilizing a modified patient schedule, for instance, starting with 1/3 in person and 2/3 of your patients seen via telehealth. You can use creative scheduling to allow for rotation of providers, minimizing people's potential COVID-19 in-office exposures while increasing the face-to-face appointment volume. But remember, this is really just step one for reopening. We have a long ways to go. Moving on to scheduling and triage. Just following up on the incremental opening, scheduling and triage will require some special attention during this time frame. With initial limited availability for face-to-face visits, it's important to identify those who can appropriately be seen safely via telehealth versus face-to-face. I think clear communication from physician leadership to staff is critical here, as invariably we will depend on staff in this space. It's necessary to triage the necessity of each visit to identify patients who need to be seen in person. Prioritize those with complex chronic care needs and acute visits. Consider delaying some visits, like well visits, until future reopening phases. Moving forward to screening, regarding pre-appointment screening, we want to screen all patients for COVID-19 symptoms and exposure history. All patients should have their temperature taken and a questionnaire screen at the time of their appointment. And the CDC has some sample forms or sample templates for staff to use if those are needed as well on their website. Going to patient communication. Communication is critical throughout to help reduce anxiety and uncertainty. Use the tools at your disposal to communicate as effectively as possible. Let your patients know what to expect from their appointments, both for in-person and telemedicine appointments. Let them know when your practice is reopening for face-to-face visits and other specifics, such as if they should remain in their cars, wear a face mask, go straight to the exam room after checking in, and etc. You'll want to provide assurances of all the precautions that you're taking to protect their health and safety during their appointments and time within your clinic.
We'll move on to visitor policy here. All major recommendations from all the national guidance are suggesting that we should advise patients not to bring a companion, including family, friends, partners, to appointments. We should include that with parents who are the patients themselves, asking them not to bring their children with them if at all possible. Recognizing, of course, that there are going to be scenarios where visitors are not only going to be wanting to be there, but are also necessary to the care of the patient, whether that is a underage patient, a minor patient, a pediatric patient that you're taking care of, whether that is a patient that is elderly that relies on their adult children. This is a time to get a little bit of creative. Of course, there are going to be individual considerations that will need to be undertaken in terms of determining when a visitor should be allowed and when they should not be allowed. And that is a true clinical judgment. However, in cases where it may be advisable that the patient, where the patient is fully functional and they do not require a visitor with them, but perhaps want to have someone with them because they're anxious about the appointment, tips and tools that we've seen in many of our clinics that have been successful is ensuring either the significant other or family member or friend that you will call them while they are waiting outside, while they are waiting in their car, so that they can be part of that visit with the patient in that face-to-face visit. If you do decide that a visitor is necessary for the visit for whatever reason, the visitor should also be screened the same way the patient is screened, including temperature checks and questionnaires. If the visitor screens positive, they should not be allowed in any patient care area. Visitors should also be required to have the same face mask that our patients are being advised to use. With the face mask, we'll get to that here in a second. So for PPE, as we alluded to earlier, all healthcare providers and staff should wear surgical face masks at all times. This comes from all of the major national guidance from the AMA, AAFP, CDC, and CMS. This has been shown for universal source control, as well as some protection from viral shedding if the patient is COVID-19 positive. There is some limited weak data regarding goggles or face shield. That data has not been extensive, but some practices have taken an approach of universal face shields or goggles for all patient encounters, regardless of any aerosolization that may be occurring in that encounter. That is something that would need to be made at a local clinic by clinic and provider by provider decision. But just so you know, there are some articles related to the effectiveness of face shields during the COVID-19 crisis in low risk situations, like non-aerosolizing exams. All patients should be asked to bring their own cloth face covering. These can be bought, they can be made at home. Again, this is for universal source control. With these face coverings, there is a great CDC resource that patients can be directed to if they indicate to your staff while on the phone being triaged that they do not have a face mask. It's a very quick tutorial on the CDC website of how they can make their own face cloth mask using a rubber band and an old t-shirt. Scarves are also acceptable. It will be a local decision by the provider and the office, whether patients that show up without their cloth face covering, what to do with those patients. There is, of course, concern that if a patient is showing up for care and they are turned away, there is some concern for patient abandonment. And so you would want to have a plan in place for that. Most providers are taking the approach that patients are advised to bring their own cloth face covering, and those patients that show up without a cloth face covering, if adequate PPE supplies allow, that the staff do provide them with a surgical mask to wear during the encounter. There are some groups that have received donations of cloth face masks. Those could also be used during the encounter to be given to patients that show up without their own cloth face covering. In terms of a patient that screens positive on any screening, again, it will need to be a local decision and it will depend on local logistics of the clinic. But in those clinics that have determined that they will not be seeing any respiratory patients or patients with fever, there should be a plan in place for how to appropriately triage those patients, whether that means through telehealth, whether that means through a partnership with a local urgent care, or whether that means perhaps screening them outside, whether that's in their car or some other area that does not include bringing them into the clinic. Really important is that office managers and administrators should be very closely monitoring your PPE supplies. In my clinic and in our group, that's done on a daily basis and reported out daily. And because we have seen the backlog of deliveries for PPE, it's important that you get your orders in ahead of time before you're running low on that. I know that's obvious, but of course we want to make sure that it's safe for our staff and for our providers to be seeing patients face to face. In terms of protecting staff, all staff and providers should be screened daily. A universal recommendation is that all staff and providers should have daily temperature checks before beginning work. All staff and providers also should either by a questionnaire or some other affirmative action be asked questions related to symptoms. Any provider or staff member that is symptomatic, has had exposure risk, that would be considered higher risk, should not be allowed to work that day. If you are part of a larger group that has access to employee health, they should be directed to employee health. There are some decent recommendations from the CDC in terms of how to determine when it's safe for a healthcare provider to return to work. There's a lot of criticism related to that. However, you can find that guidance on the website that's listed there. It's recommended that if you are not following the CDC guidance, that you find and formalize what guidance you will be following in order to clearly communicate to your staff and providers how you'll know it's safe for them to return to work. One more caveat on this, this is a very important piece for our patients that are afraid and fearful for showing up to our clinics. Most patients in a recent survey, when indicating why they felt fearful about coming to clinic, was that they were afraid not that they were going to get COVID-19, be exposed to it by other patients, but instead that they were going to be exposed to it by their healthcare provider and their staff. And so it's important that you're communicating out to your patients the steps you're taking to ensure that they are as safe as possible seeing you in the clinic. Finally, we'll move on to facility considerations here. Again, this will depend on your local logistics. Many clinics are determining that they would like to create a sick versus well area. So patients may be segregated based on symptoms, and whether that includes a separate waiting area, if that's possible based on your clinic workflows and logistics, whether that means patients that are symptomatic are screened outside, as we discussed earlier, whether that means you refer them to another clinic that has been designated a COVID care clinic, or whether that means that you are as effectively as possible moving patients from the waiting area to an exam room without having them sitting in the waiting area around other patients. If you are able, best practice would allow for creating a non-COVID care clinic. So if you're a part of a larger group, you could have either an entire clinic or a part of a clinic designated as a non-COVID care clinic. in those settings, staff and providers should not be crisscrossing from a non-COVID care clinic to a COVID care clinic or COVID care part of the clinic. So if you are a part of a multi-partner group, you would perhaps have one of your partners seeing patients in that COVID care clinic on one day and alternating that schedule, as an example. In either case, this allows for a reduction in transmission possibility and cross-contamination, and again, puts out as a communication to your patients that you are taking their safety as much as you can to separate out any patients that are symptomatic. Along with this, you do want to minimize time and waiting areas. Recognizing, of course, that as we return to face-to-face visits and as we have more face-to-face visits, you're going to have perhaps patients that you would expect to be sitting in the waiting area based on our pre-COVID-19 expectations and workflows. However, what we would encourage is if you are a single practitioner, for example, that you would move those patients to any of your available exam rooms as quickly as possible, and patients that are not yet ready to be seen because there are other patients in the clinic, that they be allowed to wait outside or in an area that does not force them to be in close contact with any other patient. Of course, any patient that is inside should be wearing a cloth face mask for universal source control. At a minimum, all chairs in the waiting area should be spaced at least 6 feet apart. And you do want to try to maintain low patient volumes. One suggestion in doing that, of course, has been telehealth. Telehealth has been instrumental in allowing us to have decreased face-to-face visits. And so one option might be to either alternate your schedule so that you're seeing one face-to-face visit alternated with a telehealth visit, or if you're part of a larger group that has multiple physicians in the office, you perhaps might schedule with your other providers so that they're on alternating schedule, where one perhaps is seeing telehealth in the morning and face-to-face in the afternoon. That would free up exam rooms that patients can then be brought back to quickly without having them sit in waiting areas. If you do have a parking lot outside and it's accessible, you may want to set up signage in each parking space that patients can call the office from, so that way you can do the check-in over the phone while they're still sitting in the car, again, minimizing time in waiting areas. Another way that you can maintain low patient volumes would be to have patients in a lower volume but longer throughout the day. That may not sound all that attractive, but it is a way to do it. So perhaps you expand your hours from an 8-hour workday to a 12-hour workday, or perhaps you open up evening hours or weekend hours to accommodate lower patient volumes, but still seeing the same number of patients per day. Of course, important in facility considerations, not only for source control, reducing infection, but also for communication to patients that our facilities are safe. You do want to ensure that you are doing enhanced sanitation using a CDC or FDA approved product. All surfaces in exam rooms, anything that is a touch surface, should be wiped down in between each and every patient visit. Staff should be trained on that, and that should be reinforced. All exam room waiting chairs should be wiped down after each patient is in them, and surface areas that have frequent contact throughout the day, such as an area where you might be doing dictation, or an area where staff might be sitting to do work, lab surfaces, etc. All those should be frequently wiped down. Some guidance does suggest that areas of congregation, such as employee break rooms, you might consider shutting those down, at least during the phase 1 approach to reopening. This would limit staff being in close contact with one another. So that is the highlights of our official guidance from CMS, AMA, and AAFP. Again, we tried to distill down all of the various guidelines that have come out in the preceding weeks. While we may not have covered every topic, we hope that this is a helpful guide in looking at reopening and resuming face-to-face visits. I will just make quick mention that the FMA did put out, I believe it was today actually, a phase 1 using the Florida guidance, Safe, Smart, Step by Step, reopening your medical practice, which does talk a lot about very similar topics that we've discussed here, including the teletriage program. But there is some great information in there, including a pre-visit screening script that you might want to utilize for your staff. So I just wanted to put that as a plug there, since that was not part of this presentation. So next, Dr. Rensberry and myself just wanted to discuss briefly some lessons learned, and I'll start here is that I think that one of the most important things that you can do, especially if you're not part of a larger group, would be to find community partners to pool resources. We've discussed that throughout the presentation, but I really think that that is an important thing for you to do. Most of us belong to our local medical societies. You also, of course, because you're on this presentation, I know you're an active member of the AAFP, and we are a local resource for you as well. And if we don't have the answer, I promise you, Jay and all of the amazing staff at the AAFP will work to find you an answer. So make sure that you're finding community partners, realize that you're not in this alone, be flexible and be honest with your patients, with your staff, be timely in your communication. And lastly, communicate as best you can. Keep communicating, especially to your staff, who are the front lines really with dealing with your patients and talking with your patients on a daily basis. Make sure that you have a unified message going out. Dr. Rensberry?
Yeah, I just want to piggyback on the whole communicate section. I think it's really important to stay educated on all the recent news that's coming out, and what the local statistics are, state statistics, and other distractions that people may have. They're going to ask you about those, and it's important to be able to speak intelligently to those, to your patients, and again, just be as easily accessible as you are able to be. Communicate, clearly, frequently, with and timely, like what Craig said. And I suggest, also ask patients directly, what their COVID-19 questions and concerns are. I've found that that's really brought out several other issues with different patients that I've had. And I'm sending out mass emails. I'm trying to do some social media posts. I'm talking to my patients very frequently over the phone. I think that that's really helped keep people's sanity throughout this time frame as we've been going through this whole pandemic.
And with that, we're going to open it up to questions and answers. And we were purposely mindful that we wanted to keep this very short and sweet, to the point, to allow for questions here. And it looks like we do have some questions here in the chat box. Dr. Scuderi, I'll turn it over to you to moderate.
Excellent, and I want to thank you both for a fantastic presentation of important information so far. The first question we have is, telehealth is an important tool to access physicians, but only for those who have high-speed internet access and smartphones. Many patients facing already socioeconomic hardship cannot afford the technology needed. How can we help them utilize this telehealth?
So I'll start with that, and then I'll turn it over to Dr. Rensberry. I think that is it's a great point, and not only is there a cost consideration and access consideration, but we also see with a lot of our patients, it's a understanding of the technology. And so especially for a lot of our elderly population, our older patients may have difficulty either because they don't have access to a smartphone or just because they're not used to the technology. And so it is a challenging aspect of this. I will say that CMS did recently allow for audio only visits, which is helpful. I think it's helpful from a reimbursement standpoint and making sure that our clinics are able to continue to see patients, because a lot can be done over the phone only. But we all know that a phone visit only does not take the place of a true in-person physical exam. And so while that is very helpful, that they've allowed for that, and most, if not, well, not all, but a lot of payers have followed through and followed suit from CMS allowing audio only visits, that doesn't necessarily address our ability to appropriately assess our patients. And so I think that that is a bigger question in terms of access, especially for our rural areas that may not have access to broadband, that may not have access to affordable internet service or cell service. I will say that from a practice standpoint, there are a lot of great resources out there for telemedicine apps. Prior to COVID-19, my practice, our large group was not doing any telemedicine. Like many of you, we quickly had to ramp that up, and we were able to utilize free software that exists out there that's worked relatively well. And so it does exist from a practice standpoint. The question, of course, went more towards how do we get that access out to patients. But I think that that also involves advocating from an FAFP standpoint too to our lawmakers in terms of expanding access for our patients, because I don't think telemedicine is going anywhere. I think it's here to stay, perhaps in a slightly different format, but it's definitely here to stay.
Yes, I think your point was that it's not everyone has the high-speed internet, and not everyone has devices or technological expertise that they can manage these things. And I think that, you know, what Dr. Levoy said really addresses it. We're using phone conversations, and I think that's really what this whole point is to try to identify those patients that we need to see in person, because we're now at that point where we can bring some of those people in, and those are so maybe people who have difficulty with technology would be another category of person of visit that might be needed to be seen in person, as opposed to over the phone or using a telemedicine application.
Thank you. Let's go to the next question. It is, medical offices are already experiencing a 60% drop in revenues. When facing economic hardships, how can we ask medical offices to maintain low patient volumes at this time?
So I'll start again there. You know, low patient volumes, I think the recommendations are not necessarily talking about a cumulative effect. And again, this is, I may have some disagreement here, but again, from the national guidelines here, what they're suggesting is that your total daily volume in theory could be the same if you had expanded hours. And so perhaps instead of seeing 4 to 5 patients per hour, you're seeing 2 to 3 patients per hour, but you're expanding the number of hours. Now, the corollary of that is that you're actually working longer days. And is that fair? I'm not saying that that's fair, but that's where the guidelines are coming from. But I think that if you use a combination approach of telemedicine as well as face-to-face visits, that your number of visits per day can remain relatively the same, depending, of course, on your patient population. The area that I practice in is in an area that is a little bit younger demographics and has a little bit better access to technology. And so I'm fortunate in that regard, in that many of our patients, if not all of them, actually want to do telemedicine because they don't want to come into the office. And so we've seen a radical shift in most of our patient visits to telemedicine. I understand that not everyone has that ability based on their local demographics. But I think it's just, it has to be a phased approach. And based on some of the numbers that we're seeing, again, locally, we are seeing a little bit of a resurgence here locally in Pinellas County, which roughly translates with 2 weeks post when we've started to reopen things here. So I think that it behooves us as practitioners and frontline providers to protect not only our patients, but protect ourselves and our staff. And one way to do that would be to have lower patient volumes.
I think this is really a tough question, you know, from a practice standpoint, but it's important to remember that the goal is to bring the volumes back as quickly as safely possible. And as we make headway, this should improve. But the reality is it's just a difficult situation, I think, for everyone.
Thank you both, and it's a very challenging question. The next question that was sent in is, do we have to keep a temperature screening log for the patients that check in?
If you want, I can attempt to go after that. I don't think that you need to keep a temperature screening log, but what the guidelines, the way I read them is we want to screen every patient as they come in, which includes a temperature and then a couple of questions to see if they have any symptoms of coronavirus 19. And so I've been putting those temperatures into the vital signs for that patient. And that's been the temperature, and that's the way I was reading this.
Yeah, and I would agree with that. Just the temperatures that we're getting at the door is the temperature that we're recording in their vitals in the chart.
Okay, thank you. The next question we have is, do you have any recommendations for patients with chronic illness who have recovered from COVID-19 but have persistent positive nasopharyngeal tests? Would you allow them to have an in-person visit if they need one?
That's a great question. The CDC actually attempted to answer this slightly, but what I would say to this, one is, depends on if, did the question say whether they were symptomatic or not? I'm sorry, I missed that, Dr. Scuderi.
The question said that they have recovered at the time.
Okay, so they've recovered. So essentially they're asymptomatic. So the CDC has put out guidance for patients that have tested positive and they've done a symptom-based strategy versus a test-based strategy. And what the guidelines essentially say is that as long as at least 3 days have passed since recovery, which they define as resolution of fever and not having to use any antipyretics, and they don't have any respiratory symptoms, and at least 10 days have passed since the symptoms first started, that those patients may discontinue isolation, which would include returning to clinics. Now, I think that has to be a patient-by-patient basis, and obviously if they have access to telehealth, you might want to have them do a telehealth visit as opposed to coming into the office. Now, if you are undertaking a test-based strategy, that becomes a little bit problematic because we've seen persistent positive NP swabs on patients well after the time frame that the CDC has put out here in terms of when we would expect based on a symptom-based strategy. And so if you are following a test-based strategy, my advice would be, if they're continuing to have positive NPs and that's the strategy you're utilizing to determine when to discontinue isolation, that patient either needs to be seen separately in full PPE or via telehealth. But that's my perspective on it.
Yeah, I was going to say, I think this would be somewhat clinic specific, and you can do creative solutions like when they would be seen, like what time of day to minimize exposure to other patients or staff. Bring them in through a different door, like a back door or something. Go straight to the room. Make sure you use all PPE, that kind of thing.
I know it's taken a lot of creativity for all of us to continue to see patients, and it seems like every day brings a unique scenario to think about or a new challenge. So appreciate the answers. Next question is, when is the cutoff when there will no longer be pay parity for telehealth? Do you have any insights on those?
It's a question I keep asking to our senior leadership because that's really important for us. And they've not heard anything from CMS as of my call with them last night, but I don't know if anyone else, maybe even on this call, or Jay, if any of you all are privy to that. I haven't seen any information come out from any of the payers, including CMS.
Yeah, this is Jay. There really hasn't been anything necessarily from CMS, but rest assured, as the payers in the private space typically follow Medicare as they did in this instance, they'll do the same thing. But as soon as we obtain that information or hear what's going to happen with that through CMS, we will absolutely let the membership know.
Excellent, thanks, Jay. And so the next question is, what do I do when the IgM antibody test is reported as equivocal? Do we have to retest?
So I would start by saying that it depends on what your utilization is for that. The FDA has come out, as well as the CDC, saying that antibody testing should not be utilized for diagnosis of COVID-19. That really we should be doing that off of PCR and not off of the antibody testing. As far as if it's equivocal and you're looking for more of an immunity response, I don't know that I have the exact answer for that. I don't know that anyone does, because we don't know how long immunity is expected to last and the exact conversion from IgM to IgG. I suspect that if it is equivocal, a retest would likely be warranted. But again, if this is more for a diagnosis of COVID-19, I would caution against using antibody testing at this time.
Thank you. Next question, and this one maybe, Jay, I think we probably like your insight on this. This is, in my experience, one can purchase PPE, including N95 masks online at horrendous costs and often only in bulk. Price gouging is the norm, and sometimes the PPE is of substandard quality. Can we ask the state of Florida to purchase PPE in bulk to distribute PPE to all medical providers and facilities?
Yeah, I'll take a crack at it. I mean, originally the stockpiling of PPE that the state had at its disposal was supposed to be distributed through the different health departments through emergency management. As that was done, it was probably not done, as most of our members would attest to, at the medical practice level. It was done through the health facility levels, the hospitals, where the more acute cases and treatments of patients, particularly on ventilators and critical care, was being conducted. In terms of the price gouging, there's, it's a really difficult issue. I know the Attorney General in our state, Ashley Moody, has worked on that. We've heard, information from them, but it's kind of like many things. How do you catch that, and how do you enforce it? And that had a lot to do with the reason why we had done the 3 different distributions of masks. And this is being completely vulnerable and open, is we had a connection to a supplier that we trusted. If it hadn't been someone that we were familiar with, there's no way that we would have even considered buying the 3 different caches, if you will, or amounts of PPE that we did. So it remains to be a very difficult issue. We continue to try to find those vendors. That vendor for us has dried up, unfortunately, but if we do, we'll put it out there. I know there are some medical societies that are providing it, such as in Central Florida through the county medical societies, but it may take some time to get that if you're capable of ordering it. But it is a great question. Certainly, we would encourage everyone to be very careful, buyer beware in this case, in terms of any purchasing of PPE.
And Jay, can I just take I'm just going to take a tangential turn off of that question, because this is something we didn't address in this conversation, but for anyone who might be doing elective procedures in their office or otherwise, the governor's announcement on his recent executive order had multiple gating criteria, if you will, that had to be met prior to allowing resumption of elective procedures. This mostly related to obviously your ambulatory surgery centers and your elective surgeries, but 2 of those gating criteria that had to be met was that the facility had adequate PPE to complete all procedures and to respond to COVID-19 treatments without the facility seeking any additional federal or state assistance regarding PPE, and that the facility had not sought any additional federal, state, or local government assistance regarding PPE supplies since resuming elective procedures. And the governor's office made clear that physician practices would be expected to comply with both of those in order to be able to resume performance of elective procedures. So not directly related to that question, but I just wanted to take that opportunity to make everyone aware that that is part of the executive order in terms of any elective procedures that might be done. Maybe a very minority of any of our listeners, but just in case that applies to you.
It's a good point.
And that is the last of the questions. I just want to ask Dr. Levoy, Dr. Rensberry, do you have any closing statements or anything you want to share with the attendees before we close tonight?
Just want to thank everyone for their time tonight. We want to reemphasize that this is truly a phased approach. A term that we like to use in our group is that it's a dial approach. You should be dialing in and dialing out your approach to seeing patients face to face, and making sure that you're really communicating and really looking at your local prevalence data, which should drive the majority of your decisions in when to ramp up and when to ramp down in terms of seeing patients face to face. I want to thank everyone for their time tonight, for the great questions. Thank you, Dr. Scuderi, for all your work in this. Thank you to the AAFP for everything they've done in supporting family physicians throughout all of this.
Yes, thank you. And I'd just like to, we've we've thrown out some ideas that were creative solutions that we thought of, or different ways to look at different things. But I think that it's important that, you know, we're all sharing the same time frame together, that we're all having to deal with very similar limited resources and similar questions. And I think it's good for us to continue to share each of our own creative ideas and what we come up with as far as to make things work as we go through each of these phases, as we start seeing patients again.
Well, I want to, once again, thank you, Dr. Levoy and Dr. Rensberry. This was an amazing presentation tonight, and there was just such great information that was practical and that each of us can take and apply to our practices every day. And just I think everyone who attended tonight, can really take something that's going to make a difference in their practice tomorrow. So we really, really appreciate this. I'd like to thank everybody who participated tonight for joining us, and not to forget to continue to visit the FAFP website. It's FAFP.org. for late-breaking information concerning the COVID-19 crisis, and to listen to any past webinars. They've all been taped. Last but not least, as you can see on the final slide, a special thank you to all 14 of the webinar presenters over the course of the last 8 weeks in helping us get through this pandemic. However, as is always the case with family medicine, we always find solutions by working collaboratively. I'd also like to thank Dr. Christy Alexander, the FAFP president, who had the vision for this task force and who has been doing a great job representing us in the media and really advocating for family medicine throughout the state. I'd like to take time to recognize the team at FAFP, Jay Milson, Adam Beamer, Jennifer Young, Deborah Walker, and everyone there has done an amazing job during the past 8 weeks putting these webinars together. They've gone seamlessly, and they've just done a tremendous job just making sure that each of these webinars just run well. And so I just want to thank each of them. They're an amazing team, and it's just been a pleasure working with them. I'll close by noting that the FAFP COVID-19 task force will continue to meet and determine ways to assist FAFP members practice in what is slowly becoming the new normal of family medicine. In the meantime, do not hesitate to reach out to the FAFP staff if you have any questions during this time or need assistance, as they will help navigate your specific inquiry. We appreciate all that each of you are doing around the state on behalf of your patients. Keep up the great work, and be well, stay safe, and have a great night. And thank you, everyone, for just doing what you do.